Hey there, everybody. It's Dr. Noseworthy. We're back again with the Inflammation Nation podcast. And this is, believe it or not, this is episode 91. It was kind of hard to project when I started this project back in January of this year. And this is November now, that, that we'd reached 91 so quickly. And episode 100, I guess, would be a pretty cool milestone to hit. And that should be just a couple of weeks around the corner. So I was thinking about this list of labs that we've been going through, right? The labs that I would and would not spend my own money on. And the whole point is to help you understand which labs are the most useful to most people in the most common situations. Remember, lab testing really is all about clarity and direction. For example, when you have a situation where you suffer from multiple symptoms in multiple systems, right? You don't have just one complaint, it's a whole bunch of different things in different places. It can be hard to figure out what the true underlying causes are. And it can be difficult to know what to do first, what to do second, what to do third, and so on. And because so many different metabolic imbalances can create symptoms that overlap with more than one system, we have to have a way to figure out where the problems actually lie. And that's where diagnostics can be really, really quite helpful. For example, the most common symptoms that my clients complain about, and I imagine if I asked a dozen of my functional medicine colleagues the same question, we'd probably come up with very similar lists. But typically people come to see me because they have fatigue. They have some kind of gut issue with some mixture of gas or bloating or distension or maldigestion or changes in their bowel habits. They quite often complain of sleep problems, whether that is a problem falling asleep or perhaps more commonly not staying asleep and not waking up feeling refreshed. They complain about brain fog, and they might also complain about focus and concentration issues or forgetfulness. Quite often they have some degree of anxiety or depression. And if it's a female, then quite often there's either some kind of premenstrual syndrome or something's going on with the peri or the postmenopausal type symptoms. And that's, I would say, a pretty exhaustive list of the types of things that we work on. And quite well, I might add. But, if you consider the list of potential causes for each of those, there are many. Like fatigue is not like a deficiency of caffeine, right? And I actually heard a doctor suggest to a client once that, well, if you're tired in the afternoon, have a cup of coffee. Well, that's kind of ridiculous, but you get my point. But, fatigue is not caused by only one thing in all people who are fatigued. It could be an iron deficiency anemia. It could be a B12 issue. It could be a blood sugar problem. It might be cortisol and stress. It could be a chronic Epstein-Barr infection, and so on, and so on, and so on. And so just going on symptoms alone is not sufficient. We have to have some way to get objective information about what the actual cause is for real individual people. Another example, brain fog. We know brain fog to be a neuroinflammatory problem, but where's the inflammation coming from? Is it systemic inflammation because someone is a pre-diabetic? Is it food sensitivities? Is it a leaky infected gut? Or maybe somebody is perimenopausal and they're just under a lot of stress with work and they're not sleeping well. And, we can create any number of scenarios that could lead us to the same outcome. And so understanding this, that figuring out what to do for any one person is really a matter of doing some detective work, which means investigation and information or evidence. And lucky for us, although we're all individuals and therefore we are all biochemically unique, we're all designed the same way. We all have energy producing systems that run off the same fuel types. Our brains all have the same lobes that serve the same functions with neural pathways, and neurotransmitter systems are all identical in design. Our thyroid systems, our reproductive hormonal systems, and so on are all the same, at least in how they're designed. And I mean how they're designed, like not in the sense of how they actually function, which is why maybe you have a thyroid problem and I don't, for example, even though our thyroid systems are identical. So, excuse me, the only way to avoid the trap of generic treatment programs, you have to have a way to look at yourself as an individual, or for your doctor to look at you as that individual person. And believe it or not, there are still docs out there in natural medicine that are using like pre-planned programs that they apply to everybody. And it doesn't matter to many doctors that your causes of the same symptoms as someone else might need to be addressed differently, because a lot of times these pre-planned programs are designed based off symptoms or sometimes diagnosis. And I tell you, what does matter to practitioners who use these canned or pre-planned treatment programs is employing something that's easy to learn and easy to deploy, like in terms of protocols, that for them as the practitioner minimize their time and their effort so they can see more people. And you can fill in the blank as why they want to be able to do that. And to be honest, if I could pull back the curtain for a moment on the inner workings of the world of functional medicine, there are financially successful groups of doctors out there that are teaching other doctors how to see, 30 or so people per day, which means the average consult visit in a normal workday was going to take about 15 minutes or so, which is about the national average, or it's actually above, just a little bit above the national average for conventional medicine. And I'm not sure if you know this or not, but on average, there are of course exceptions. The typical medical doctor spends only 7 to 12 minutes with each patient. 15 minutes is better than that, but really not by much. And so any new doctor getting into natural medicine is faced with a dilemma and a choice. Like, do they approach designing how they operate from a business standpoint where they see as many people as they can in the run of a day? Or do they design their approach with the view of doing their best for each individual person? Because for the most part, the two are not compatible. And listen, I've done this myself. I've been in a situation working in a multidisciplinary clinic where it was all about the numbers. How many people can we see? How much money can we bill? And all this kind of stuff. But I found it very unfulfilling for me, as well as for the people that I was trying to help, which is why many years ago, when I left a group setting and went out to work on my own, I developed a professional motto of see fewer people, spend more time, and do a better job. I mean, that's burned into my brain, if you will. So for me, on average, I spend 45 minutes to an hour each and every time I talk to my clients. It doesn't matter if it's the first consult or the 10th. We take time to make sure that we do things right. And so it gives me time to really listen to what people have to say and to truly partner with them as I guide them through their journey to get back that quality of life that they've lost. So if you choose to work with a functional medicine provider, ask them about how they work. Like, how many times can you expect to talk to them, and how long is each session? Do you get a chance to ask your questions? What types of tests do they typically run, and why? And that's a question that would be relevant to this little mini series. Ask them what their clinical model is. A red flag would be if they do a detox on every person first thing out of the gate. If you walk into a practice and someone says, okay, well, we do a detox with everyone before we do anything else, that's a red flag that they have some kind of a canned approach that may or may not be appropriate for you. And you also want to know if the doctor does all the consults themselves, or do they farm you out to a health coach or a nutritionist or someone else on staff that actually does the work? Are you talking to the doctor, or are you talking to somebody else? And that's not saying that people who are not doctors can't do a good job. They certainly can, but you should know what you're getting into. All right, so let's get to the topic at hand. I went just a little bit on my soapbox there, but we're talking about tier 2 testing. Remember, tier 2 is comprised of the tests that I find myself doing frequently, but not on every client. And these are, in my opinion, best reserved for cases that are most likely to benefit from them, where there's something undefined that needs to be defined, unless, of course, money is no object and you can simply run everything you want, which, of course, is doable as well. But for most clients, we need to talk about what's necessary and what's nice to have, but not absolutely required, because there are some questions we have about how someone's physiology works. It would be nice to know the answer to the question, but it's not going to make or break whether or not we can help them. It just might fine-tune our efficiency, for example. So the first test in tier 2 is a leaky gut test. Now, I know we just talked about leaky gut in the last episode, so this chat isn't about the pathophysiology so much as it is about testing strategies and which leaky gut testing do you want if you feel like that's a valuable test. So first of all, leaky gut testing has been available for 30 years or more. And in its original form, and this is still available today, the test consisted of drinking a solution of 2 sugar molecules called lactulose and mannitol test and then measuring them in your urine. It is literally called the lactulose mannitol test. And I'm not going to bore you with details of how the test works or doesn't work, but suffice it to say that when it was the only test available for decades, it's the one we used because it's the only thing that we had. But then somewhere around 2009, somewhere around there, Cyrex Labs came out with a blood-based antibody test that blew the old urine test out of the water in terms of sensitivity and specificity. Immediately, the lactulose mannitol test became outdated, and we started to understand how it didn't really tell us what we thought it told us, but at the time we had no other option. And we didn't know any better, to be honest. So how does the Cyrex Labs leaky gut test work? And I'm focusing on this not because I don't have any financial relationship with Cyrex. So no matter how many tests they run, or if they come from me or somebody else, I don't get any money. It's just I truly believe that they have the cutting edge technology in terms of looking at leaky gut. And I believe they're the only lab in the world that does it this way. So how does this work? Well, it works by detecting antibodies to two different things. And let me define that. An antibody is something that your immune system produces to basically label something as an object of interest for other parts of the immune system. So for example, if you get an infection, let's say it's an Epstein-Barr infection, you could insert any microbe. But let's say that you have an Epstein-Barr infection. Your immune system will recognize that and create an antibody to Epstein-Barr that basically is a label that says, hey, I'm Epstein-Barr, come get me. And the other parts of the immune system that are responsible for fighting an infection can find that, recognize the label or the antibody, and then go and attack it. And so when the immune system sees things that it knows shouldn't be there, or when it sees things that are unusual, it will make an antibody to it. And going one level deeper, I guess I wasn't planning on talking about the pathophysiology, but I guess we're going to get into it just a little bit. But basically, when we look at the structure, well, actually, let me hold on to that because I'm going to get into that just here in a second. So let me back up. The Cyrex test, which they call array number 2, they label or call all of their test panels arrays. Array number 2 is their intestinal permeability or leaky gut test. It works by measuring antibodies in the blood to two different things. Number one are structural proteins that normally hold the cells of the gut barrier together. And number two, a bacterial endotoxin called lipopolysaccharide, or we call it LPS for short. And with the structural proteins that the test tests for, there's actually two different types, which gives us information about two different types of permeability or two different types of leaky gut. That's right. There are two types of leaky gut. And before I can describe that, let me explain what the gut barrier looks like at the cellular level. And I understand the vast majority of you are listening to this just audio only. I do have a video version of this, but I haven't started posting it on YouTube or any other video platform. I'm thinking about maybe using visual aids and all that kind of stuff at some point in the future, but for now, it's just me and my voice. So imagine this. Let's say that you can zoom in on the surface of the inner lining of the gut. You will see that the gut system or the gut tissue is lined with cells called endothelial cells that are jam-packed together. And these cells aren't just jammed up against each other, they're cross-linked together with proteins that run horizontally from one cell to the other, much in the same way as, say, the horizontal part of a wooden fence. And at the intersection of two different cells that are cross-linked together is what's called the tight junction. That's the little teeny infinitesimally small space in between the cells. Because remember, these cells are jammed up against each other, and then they're stitched or linked together with these what are called cross-linking proteins. And it's this really teeny tiny space between adjacent cells that filters out toxins and microbes or chemicals and so on, so that they don't get into your bloodstream and activate your immune system and drive an inflammatory response. And this is one of the hallmarks of leaky gut, is local as well as systemic inflammation. And so we have a sheet of cells, which is really only one cell thick in its dimension, with each cell connected to the cells next to it with these cross-linking proteins, creating this tight junction or tight junctions. And the whole system acts like a very sophisticated filter system. It lets good things pass into your bloodstream and is supposed to filter out the bad stuff so that we can neutralize it and get rid of it so it doesn't have some kind of a negative biological effect. But these cells are not only cross-linked together side by side, they are linked to the tissues that are underneath them, what's called the basolateral membrane or the basement membrane. And so these epithelial cells of the gut barriers are anchored to the underlying tissue and they're cross-linked to each other side by side. And that's basically what the gut barrier looks like grossly at the cellular level. So we can get leaky gut in one of two different ways. The first is when something breaks the crosslinks and the cells drift apart, making a larger space in between the cells. So instead of a tight junction, let's call it a loose junction, although I've never seen that in the medical literature, but you understand the point. And things, when you have the cells that drift apart because the cross-linking proteins have been damaged, and you have this loose junction or this open space or more open space, then things that normally wouldn't fit in the space can now slip through and get into the bloodstream. And on its way going from the inside of your gut to your bloodstream, it gets exposed to what's called the submucosal tissue, which is where your immune system is, or the majority of your immune system. So that's one way we can damage the cross-linking proteins so the cells drift apart, opening a space in between them. Or we can damage the cells themselves, and the proteins that anchor the cells down below start to get damaged. And now these cells that are damaged no longer contribute to the barrier function. It's like, let's say it's like punching a hole in a sheet, for example. Now, both types of leaky gut are leaky gut. One is damage to the cross-linking proteins. One is damage to the cells themselves and the proteins that anchor them to the basement membrane. Both are leaky gut. Both create a local inflammatory response in the gut. Both can contribute to immune activation and systemic inflammation. Both can lead to the development of food sensitivity. Both let things through that they shouldn't. But the one that involves damaging the cells themselves, instead of just the cross-linking proteins, is the worst of the two because it implies cellular damage and not just damage to the protein crosslinks. Both are serious, but one is more serious than the other. And Cyrex's blood test allows us to differentiate between types of leaky gut, and therefore lets us gauge, is it less serious or more serious, depending on which set of proteins are involved. And of course, you can have both. And just to be complete, the proteins that indicate cellular damage and what we call transcellular permeability are called actomyosin proteins. And the proteins that indicate damage to the crosslinks, creating what we call paracellular permeability, are called zonulin occludin proteins. And this is far more robust in terms of testing than the old school urine test, if only because we're directly measuring the leaky gut instead of looking at some kind of an indirect indicator, leaving out for the moment that the old test, the urine test, the lactulose mannitol test, wasn't really a reliable test anyways. Now, there's another thing that the Cyrex lab, this array number 2, tests for, and that is an antibody response to lipopolysaccharide toxins. These lipopolysaccharides, again, are toxins that are produced by certain gut bacteria that fall into the commensal and opportunistic domains. Now, also, there are some true pathogens that can produce lipopolysaccharides as well. But again, in a prior chat that we had on this podcast, we talked about how the most common type of gut infection, if you will, is a dysbiotic overgrowth of commensal or opportunistic organisms that are there in low amounts and even healthy guts. So some bacteria produce lipopolysaccharides and some don't. But when you have a dysbiotic gut that is producing lipopolysaccharides, that is going to be much more serious than if you have a dysbiotic gut without lipopolysaccharides. Or, more relevant to this discussion, if you have a leaky gut without lipopolysaccharides, that's less serious than if you have a leaky gut with lipopolysaccharides. Why? Because these lipopolysaccharides are very, very pro-inflammatory. It does not take much to drive big systemic inflammatory responses. They escape the gut. They get into general circulation. They wreak havoc on other systems. And that systemically inflammatory toxin load makes everything else you have going on worse and can actually be a trigger for things that you are predisposed to that have not happened yet. That's important to know. So we can use Cyrex's array number 2 to do several things. Number 1, rule in or rule out leaky gut when that is of clinical concern. Differentiate between 2 types of leaky gut, transcellular with cell damage or paracellular with damage to the cross-linking proteins, which indicates severity to some degree and may have implications for how long we expect to heal it. And finally, Cyrex's array 2 tells us there are whether there are lipopolysaccharide toxins that we have to worry about that are amplifying and complicating the entire picture. So if someone has a positive test just for the cross-linking proteins, paracellular permeability, that is far less of a problem than someone who has this transcellular permeability with damage to the gut cells themselves, particularly if they also have lipopolysaccharides driving systemic inflammation. It's a brilliant test. When you look at the physiology of the system and look at the test, you realize, wow, this is really smart. And I'm proud to say that Dr. Aristo Vigidani, who's the PhD immunologist who designed this test, he's been a mentor of mine for about 15 years, and he's become a good friend over the years as well. So how long does it take to fix a leaky gut? Let's say you run, or someone you're working with runs an array 2 and it comes back positive. How long does it take to fix it? Well, it's a trick question because it depends on the type of leaky gut you have. It depends on whether or not you have a toxin-producing bacterial load in your gut and lipopolysaccharides, and how many other complicating factors that are perpetuating the leaky gut or maybe created it in the first place. Because if you've listened to this podcast, the episodes that we've done already where we talked a bit about leaky gut, you'll have heard me say that while supplements are helpful to heal a leaky gut, you can't just take L-glutamine and deglycyrrhizinated licorice or aloe vera or MSM or Jerusalem artichoke or so on and expect to heal a leaky gut without looking at this as a full-blown neuroendocrine immune problem. Or you might have to not just take supplements, but fix your gut in that whole gut health manner that we talked about last time. You might have to fix your diet. You might have to stop taking certain medications. You might have to fix your blood sugar, fix your adrenals, balance your hormones, start exercising, stop over-exercising, learn to say no to things, to unload your stress systems, change your external stressors as best you can, modify your environmental exposures, and on and on and on. For some people, it's a big deal. And to be honest, some people who have things like intestinal autoimmunities, irritable bowel diseases like Crohn's and ulcerative colitis will probably deal with some degree of permanency and really never have a normal gut. Now, obviously, there's some really big exceptions to that, but as a general rule, when someone has been diagnosed with ulcerative colitis or Crohn's disease, and there is a permanent immune attack on the intestinal tissues, it's a matter of making sure you control the degree of permeability rather than expecting it to be fixed and stay fixed. So now you know that leaky gut isn't just one thing. It's more complicated than that. And if you feel like you have a leaky gut, you really need diagnostics to prove you right or to prove you wrong. And then and only then can you put together a plan to tackle the type of leaky gut that you have. As a general rule, on the low end of the scale, it's going to take 4 to 6 months. On the far end of the scale, it might take a year. And in some cases, it'll never be fixed. It's just controlled or managed. All right, leaky gut testing. That was number 1 in my list of tier 2 diagnostics that are common, but not everyone needs it. Next time we get together, we're going to talk about food sensitivity testing. All right, take care.